Hello everyone, welcome back to Hot Seat Season 3. I'm OMID MOGHADDAS joining you from Tehran, and once again I'm so happy and honored to have the chance to be with you all from this educational platform. And as I always say at the beginning of Hot Seat sessions, I'm so thankful for all my dear friends and educators from around the world who are generous enough to accept the invitation and join me and join you all during this time and from this platform to share everything they know and helping all the practitioners obtaining better knowledge and understanding and improving their practice and helping their patients for obtaining and gaining the best outcome possible from their treatment. And today I have a very dear friend which we both waited a lot to make this happen during this timing, and a dear friend from United States, California, Dr. Kian Usha is here with me, joining me on Hot Seat. Hello, Kianoor, and welcome, my friend.
Hi, Dr. Moghaddas. It's been an honor to follow your work over the years and all read the books you have written and to be invited on the show. Thank you for having me.
Thank you. The pleasure is also mine. And you know, today, the topic that he chose to talk, actually, we didn't really had it over the past 83 sessions on Hot Seat. We talked about sinus graftings. We talked about so many aspects in implant dentistry, but today he will be focused on minimally invasive implantology and specifically minimally invasive sinus augmentation procedures, which I think going to be interesting for so many of you watching right now. So before we go to the presentation, because as you all know, for sure, we will have a great discussion at the end about the topic. But before we start the presentation, I would like to have a short CV of Dr. Kian Usha for all of you. And then I will ask him to share the screen and we will enjoy every piece of his presentations. And then for sure, as I said, we will have a great discussion on the topic. Dr. Kian Usha is a practicing dentist and also an entrepreneur from Palm Desert, California. As a traveling healthcare provider, he has practiced in more than 300 offices. As a businessman, he has built numerous co-brand, private label, and peer-to-peer partnerships in the healthcare industry. Dr. Shah completed his undergrad studies at Western Illinois University, where he earned a Bachelor of Science in 2000. Also graduated in 2006 with a doctorate in dental medicine from Southern Illinois University. He completed an MBA program at Brandman University in International Business in 2016. His participation as a Fellow of International Congress of Oral Implantologists, ICOI, Fellow of the California Implant Institute, and Fellow of the International Academy of Dental Facial Aesthetics has culminated in his mastership and diplomate status of the International Congress of Oral Implantologists. He has been in various roles as founder, owner, chairperson, CEO, president, managing director, partner, associate, and consultant for a variety of domestic and international related business matters. He is also the founder of the International Extraction Academy and the founder and the host of historic 2018 Global Summit in LA, United States. Also, he currently serves as a key opinion leader for a host of companies and organizations. In addition to his expertise practicing general dentistry, he practices in the fields of prosthodontics, periodontics, endodontics, pedodontics, orthodontics, and oral surgery. He reads, writes, speaks English, German, and Farsi languages, and I'm so happy to say that he's my Iranian fella, and now he's one of the most successful practitioners in the United States, and hopefully I meet you, my friend, soon in person. So with no further ado, the platform is all yours. You can share your screen, my friend, and we enjoy every second of your presentation, please.
Thank you for the kind introduction. And it's, again, an honor to be on your show. I'll go ahead and turn over the presentation to a full screen mode here, and we can get started. Do you have me on the screen? Excellent. All right. Thank you. My name is Dr. Kian Usha. Today, I'd like to talk to you guys about minimally invasive implantology and sinus lifting. I've been placing dental implants since 2007 and have sort of focused most of my practice, in addition to the full mouth rehabilitations, on implantology. Throughout my travels, I used to go into many different offices, work with many systems. So I've always had a keen interest in implant design and procedures that would be of beneficial to patients. Just as a few projects that I'm involved with, you can find us in pertaining to the doctor-to-doctor movement and the Global Summits Institute on social media, where we aim to maximize collaboration between doctors devoid of third-party influence, be it academic, administrative, or financial. And we have grown tremendously over the last 7 years. And the ideas that came out of the doctor-to-doctor movement led to the Universal School of Health, which begins with increasing the acumen of our colleagues, particularly in the field of business as a starter, where we lack, which will also subsequently lead to multiple professional schools with faculty from around the world, some of the most esteemed lecturers and educators that we have recruited through the pool of our colleagues. The Universal School of Health will be located its first campus in Florida, specifically Clearwater, Florida, and we will begin on January 20th, I believe, is the date they have set for the first class to start, and it's located next to an award-winning hospital, Morton Plant Hospital. It will be very futuristic, with newer concepts implementing technology and artificial intelligence into the realm of healthcare. Another project that came out of the doctor-to-doctor movement is the Global Accreditation Program, which is, if you see the seal of acceptance, the Hippocratic seal of acceptance, I should add, a doctor should note that this organization has gone through a rigorous process by, for, and of doctors, and does not infringe upon the rights of patients and doctors in any shape or form, nor interferes with the practice of medicine and healthcare, nor interferes with the patient-doctor relationship. The HEX Commission was instituted throughout our leadership, and essentially there are representatives from medicine, dentistry, optometry, pharmacy, chiropractic, and medical philosophy, no outsiders. And we'll be conducting our 4th public meeting this December on 12/12/21, where we have doubled the commission, and also we'll have 300 new doctor members in the top 100 categories, in addition to 300 currently existing. I invite you to look at the HEX Commission and its criteria as a global effort to address the integration and globalization of healthcare at once. They're also involved in the podinars that we do. These are complimentary educational seminars conducted on the weekends where leaders come and they voluntarily provide the educational material that others can benefit from. And we have conducted over 200 of these since last year. And during the height of COVID, we reached over 2 million of our colleagues in the healthcare industry. So this is very much liked and appreciated from around the world, and there is no monetary anything. It's for the sole purpose and the love of learning and passing on education, the core concept of the doctor-to-doctor movement. I invite any doctor that's looking in who would like to nominate themselves. Our ideas and projects come out of the world's top 100 doctors. And they bring and donate their time and efforts, and we subsequently enable and empower other doctors, and we believe that to be the most logical way of fixing a broken healthcare system worldwide. It was always used to be about patient-doctor relationship and care. In the last 4 or 5 decades, marketing and other special interests have sort of deviated from our main objective of helping patients and earning a good living while doing so. Also, for my personal clinical practice, I had interest in extractions, which developed into implants, which developed into much more complicated oral surgery procedures. So we developed 3 verticals, starting with the International Extraction Academy, Global Summits Institute, as well as the Academy of Oral Surgery, where we try to help our colleagues that have interest in oral surgery to get more involved in implantology, because ultimately you have 2.5+ billion people that are in need of this procedure, that have edentulosum of some kind, 1 or more teeth, and there's not enough clinicians to care for these patients. And we need more of our GPs to actually learn from the specialists and work with the specialists and do the simpler cases themselves, especially when patients present with pain that needs either an open emet or an extraction of some kind. So at GBR, those procedures are often very easily done with well-performed extraction procedures. No such thing as an atraumatic extraction, as you may know, but ultimately there's many ways of doing it better. I'm also involved in a project that I like doing. I like engineering. I like finding problems to solve them. The problem that I've encountered in my clinical practice on All-on-X is it takes me a long time to take the screws out, to take all of the Teflon or cotton pellets and cavet and whatever you have, your access hole screwed off to clean the prosthetics. So I've been very obsessed with finding a solution that is not a straight line access to a screw, but can be done at 45 degrees, at 90 degrees, at 135 degrees. And we have invented the first system based on a wheel mechanism that will allow fasteners to be fastened in any scenario where also the fastener head is removable in some embodiments, and the anti-skid element is removable, or a shank is removable. And those can be found at the Universal Fastening System. We are currently in the process of also staffing and launching that company in Florida as well, which will have many applications, not just in dentistry, but in every industry that uses fasteners. Nails, rivets, bolts, nuts, things of that sort. It's a passion of mine. So with that said, let's get into the crux of the matter today. Why minimally invasive implant treatment? In my years of practicing, I've conducted all the procedures, lateral sinus lifts. I've done massive flaps. I've used guided systems, and you name it. And in my experience, the minimally invasive approach that I will be talking to you guys about will have a much faster healing, less pain, less invasiveness, less changes to the local topography and damage to the soft and hard tissues, and minimal usage of additional materials. You talk to some specialists and some researchers, some believe that certain grafting material actually interferes with the healing process, and minimal number of surgeries. And how do we get this done? We do this via a direct guide system. A direct guide system, which means involves no sort of flapping. It involves no incision larger than 1 millimeter. You never change the local topography or morphology. And you essentially place your implants in a very controlled and a smart way where you can make changes during your procedure. I have an 8-hour lecture on this that I do for the Academy of Minimally Invasive Implantology about how to do this. But today we're going to focus on one chapter and one chapter only, and that will be the sinus lifting process. Take a look at these minimally invasive guides. We use them. A lot of the clinicians that I highly respect recommend them. If it works for them, fine. For me, to do this sort of procedure anymore is too invasive, knowing what I know, and then the healing time and all of the things with zapping a bunch of bone away, and I used to do all of those, but I don't do it anymore. I found a better way of doing these type of treatments. So with your current digital guide system, you're going to have error of digital source. Even the slightest amount of change or an unaccommodated scenario will cause you to either place the implant improperly or expand your socket too much, or have all kinds of problems on a day where you have done all of your homework and you're ready to perform. A minimal invasive treatment is impossible in case of guided bone regeneration. And as stated, you cannot change the treatment plan during the operation, and you have the possibility of bone healing. A lot of things that are actually out of your control. I'm currently working with an implant called a MagicCore. If you guys go to conferences, you know all about bone level implants, micro pumping, micro gaps, peri-implantitis, peri-mucositis. abutment fractures, gingival recession. You constantly hear about those in the lectures, and you hear evidence to the contrary between different implant companies or whatever they tend to claim. But the fact of the matter is that the stresses are forced in an area, if you look on the right side, at the bone level, and it's not a bone-driven type scenario. And a bone-driven type scenario with a good prosthetic connection, you have less of those worries. For example, if you have a screw-retained scenario, you have it inside the crown versus at the neck. It's different, whole different biophysics. You don't have any tissue level implants. You don't have those micro gaps and noxious odors, the micro pumping, the screw loosening. It happens much less, and the issue that we encounter there are aesthetic concerns, but we'll get to that as well. So what I'd like to talk to you guys about is a bone-driven implant treatment with great prosthetics that will be able to accommodate any kind of lateral discursive movements and those things that we're concerned with. Minimally invasive GBR techniques in certain scenarios in the sinus lift we'll talk about, and the minimal incision, and applying biological concepts based on implant design. So let's go back one more. Okay. So let's talk about minimally invasive implant treatment when your sinus residual bone is 4.4 to 6 millimeters long. There's two different ways, 4.4 to 6 millimeters tall or less, where we have different techniques for the sinus area. So vertical augmentation is the visual method, and the GBR within the maxillary size is the closed defect blind method. So GBR within the sinus is actually blind method. However, this could be applied to concepts of tissue engineering. This is one conclusion we draw, where you secure sufficient residual bone height in the maxillary sinus area. For successful GBR with maxillary sinus, you have bone forming cells that need to be present. You need space for regeneration to be secured and maintained. And your sinus membrane needs to be precisely elevated in a targeted area. And the region should not be infected, or you should probably go and wait till that infection resolves before you attempt it again. So in a crestal approach, we are indirectly exerting force on the sinus membrane, sometimes with water, sometimes with bone grafting material. The practitioners cannot control the amount and direction of the force. The force cannot be exerted precisely on a targeted area. And the concept and technique that I'd like to talk to you guys about is the very, very specific pre-planned pressure that we apply to a certain area to lift it. So it's impossible to get results, and the sinus membrane often gets damaged or ruptures, or material seeps through, and we have other complications of sinus. The latter approach is force is directly exerted on the sinus membranes with sinus correct. If you don't have good manual dexterity, sometimes you perforate it. It's very invasive, and there's a high risk of complications and acute sinusitis, which you guys know about, which triggers numerous medications and post-operative protocols. And you're obviously in a position to damage anatomical landmarks, including the posterior superior alveolar artery. It may be possible to get the same result in a much less invasive scenario, and that is what we are here to discuss. So is the sinus membrane really a mucous membrane? If you observe it from the nasal cavity, it is a mucous membrane, but if you observe it from the oral cavity, you're looking at a periosteum. And a periosteum has certain features that we need to discuss. The attachment force is always going to be lower. So sinus membranes can be safely detached since it's a periosteum. So attachment force is weaker in the general, little or no Sharpie fibers there, right? Periosteum of the sinus membrane has an extent of elasticity up to 30%. So attachment force within the sinus is not evenly distributed either. So the conclusion we can draw from that is that if we can successfully control the force applied to the sinus membrane, we can detach it without damaging it or ever really coming close to it. So if physical properties of the sinus membranes have changed due to inflammation, you can expect a pus and those kind of things in your preoperative analysis, and abort your treatment until that's resolved. If the force is not controlled to detach the sinus membrane, when the force changes during the application, and when the force applied to sinus membrane is extensive. So the conclusion that you draw is force applied to sinus membrane is important unless there is pus in the sinus. So, methods to detach the sinus membrane and our minimally invasive approach. In order to carry that, you can use the crestal approach that we discussed. And in the crestal approach, naturally, you won't have to do the lateral and all that invasiveness. You can control the amount of direction of the force to be exerted on the membrane by actually having a core under the membrane that prevents you from getting to the membrane as you're lifting or doing the lifting procedure. So the targeted membrane sinus area is held together by a core, and you're exerting that pressure on that core in a very controlled fashion. And since the sinus membrane is quite thin and weak, you must have that core that's already attached to it to get the lift done. And that's the core of the discussion that we're talking about today. So there's two ways of doing that. One way, you can pin it in the center and lift it after you have done your preparation, which we'll go into detail. Or you can actually grab a piece of that bone and utilize that to lift it if you don't have enough bone. If you see on the left side, you have more bone, so you can do this crestal method. You could do the same that you see on the left side, on the right side, where you have less bone, but holding an entire block is a lot more effective that we have seen, and I will display to you via CT scans and x-rays and other things in subsequent scenarios. So you can apply and hold the sinus membrane and elevate it. It can be elevated up to 5 millimeters in this scenario without rupturing. It can be applied regardless of what shape and divots and dips you have in your sinus floor. And no bone grafting is needed in this material. Now, this is called the bone expansion and bending technique, BEB, and that requires you to have 4 to 6 millimeters of bone in a 4 to 6 millimeter bone scenario. In a 7 millimeter bone scenario, you likely can get a 7 millimeter implant in there, if that's what you desire to do, or you can also lift it accordingly with the same concepts. But if you go less, you should really look at the CMC protocol, which would be the next subsequent discussion. So when you're applying an instrument that is tapered this way, as you're tapping it down, the forces will cause the bone core to always be larger than the tip that you put it in, and help you with the fracture of the sinus floor if you approximate how close you get to the sinus floor in your protocol. So in this scenario, we have the sinus. Let's say we go in with our guide pin, and the guide pin is a diagnostic first step in this approach. And you take your CT scan, and it will allow you to, after you pierce the cortical plate, allow you to orient properly and follow a set of pin-guided steps to get to your working length and change your direction, and be able to do the same. This usually flattens the core that you have left behind, so you can go to your next step, be it your tapping to break that sinus floor, or to place your implants, depending on what is on the agenda for the day. So in this scenario, 1 millimeter short of the sinus would be able to be used for a BEB protocol. Later, I'll explain to you why the CMC will require 2 millimeters short of the sinus. So there are instruments designed to do this, and when you do the tapping, it's very controlled and it's very, very mild with certain instruments. So in this scenario, the magic drill that we use to get there makes a small indentation on the floor, and the tapping will guide the brake that will allow us to lift it. We also recommend that after the lift protocol happens, and that you go back into the sinus, because you have it's loose and it's still attached, and you can remove the rest of the core. So as the blood rushes in that area, you can also place your implant accordingly. All of these things reduce your healing time and reduce your post-operative pain. I barely have any pain with my patients that are getting minimal invasive procedures done with us. But ultimately, this diagram will show you that the fixture can be driven by a motor, and the lift has already occurred and it's sitting there to accept the implant essentially for coming in. And if you have 4 to 6 millimeter bone in the BEB scenario, you don't need any grafting material. For less, you will need, a fraction of a cc, about 0.3 cc millimeters to do the same on a ridge that is less than 4 millimeters. So the BEP sinus bump, we go in, we like to go about 1 millimeter lingual to the ridge. Our cuff height is measured based on the gingiva with 4 measurement points before we select the implant. We palpate it to kind of determine the path. We do the first drill. We still are not in our diagnostic phase. We get into our diagnostic phase once our pin goes into the cortical bone, and we can take a CT scan and verify our direction of the pin and modify it accordingly before we go to the next steps of the drilling. And again, this is a long process that I don't want to go and cover. It's a completely different way of thinking and placing implants with much better pre-planning and directed guide system, which is based on several pins. Then we drill our initial drill into the bone. We flatten out our floor. We want to be 1 millimeter short of the sinus in this scenario. We have our measurements. We know our tissue height. We do the calculation. We end up 1 millimeter drilling underneath the floor. We flatten that out. And we go to our next step. So in this scenario, we have broken through the sinus, we have done our tapping, then we drive our implant in, and everything really happens on the cuff height from the buccal gingival margin. This is the amazing scenario where you never have to flap when you do your soft tissue markers, and you decide what cuff the implant should be, and the cuff is exactly matching to the concepts of biological width to maintain that nice healing around your local site. So once you have placed it and you have lifted that core, you will see in your graph evidence that you have actually lifted the membrane, and I mean your lifting evidence that you have lifted the membrane by how many ever millimeters that you wanted, and that your first threads end up in bone, and that you have also your biological width. So here's one case study that we did for a scenario of 4, but now in the scenario of 4 millimeters, it's a little bit different. So now we need some bone grafting material. Same concepts apply, and it's called the crestal approach with membrane control versus the bone expansion and bending technique. Applies for less than 4 millimeters. I have done ridges of 1 millimeter, one case that I'd like to show you guys. It requires very minimal bone grafting material, and again, always done through the vertical crest approach. So take a look, it's very guided, and we're forming a condition of a circular bone fragment in this scenario. But the same still applies to the lateral areas that are exerting the force onto the sinus floor to cause it to have a wider base of the bone that's being fractured, so you don't have any direct contact with the sinus membrane. Here we want to leave about 2 millimeters of bone. We want to drill to about 2 millimeters short of the bone, so we can get a bigger block to lift as we are adding some bone grafting material to accommodate for the lack of the other additional 3-4 millimeters that we need. So bone rigidity and thickness will vary. So therefore, the weaker part might break first when a load is exerted, and you will see that in some of your x-rays. But ultimately, as you progress towards implantation, the rest usually lifts with it without any resistance or problems, as you have weakened that area circumferentially on the floor of the sinus. Let's take a look. FC is the force that is ultimately applied in both scenarios for the width of the block that you're trying to extend vertically, but it's always greater than your instrument in this scenario. So in order to make no contact between the instrument and the membrane during the elevation, the diameter of the bone block should be larger than the diameter of the lifter. So during the tapping, the direction of force created on the outer beveled surface is transferred outward. Thus, the bone block is always fragmented at a larger diameter than the instrument. Take a look at this 2 millimeter scenario. In this scenario, we are actually grabbing 2 millimeters of bone with a sharp instrument that has that bevel, and we never contact the membrane directly. And as we tap it, you see some wings in here that reduce your force of friction as well as increase your control. Once you leave, blood still does come in, but you need material, solid material, to create somewhat of a good stability. Although we use certain threads that are square shaped and do very well in grabbing the sinus, the sinus floor, even if you have 1 millimeter of bone, but it's just sometimes not enough. You're going to want to have 2-3 threads go in to get primary stability while you allow this implant to heal. But another cool thing about this particular implant is that you have a safety based on your cuff that prevents the implant from dislodging into the sinus. So here's a CMC technique that we did. Here's a very short one. This is a good site for a BB. This is a good site for a CMC technique. So residual boil height is less. Your soft tissue mobility you test the same way. You check your alveolar shape, you place your pin. All those things stay the same. Sometimes you have to have an additional, maybe a stopper from a root canal tool to keep it in place. But this is where your diagnostic phase begins. You can reorient your pin multiple times until you get it perfectly into the direction you want to go before you start using the drills to withdraw that pin. And subsequently, you will use another pin for your placement procedure called essentially, this concept is a direct guide system. Here you probing the soft tissue to select the cuff of your implant so you can maintain the biological width. And this is a standard protocol. Then this drill recovers your first pin. In this scenario where we have very minimal bone, we are going to apply our wings so we don't exert too much force and gently tap until we reach the desired length based on the markings on the instrument. And you apply gentle tapping and lift up to the determined depth, soft tissue thickness plus fixture length. There are certain measurements that we usually don't do in normal implantology. It took me quite some time to understand all the concepts before I started applying them, but they work amazingly well, very well thought out, and I haven't had any problems yet. The failure rate is almost non-existent now in my practice with the MAGICOR. So if bone grafting material gets stuck, use the bone pusher, you push it gently into the sinus, and you follow the same protocol and you place your implants. You can immediately see a profound initial stability, and your soft tissue starts attaching for the first time. So you're not constantly taking healing caps and tissue caps off or detach it or reattach it, which will later cause your sulcular debt to increase due to lack of the connective tissue that forms there. So you have a much better connection right off the bat that stays without repeated interference. And you have never made a incision, and the patient displays almost no pain subsequently in the cases that I've done thus far. So take a look at this. This is a beautiful scene. You did it through the vertical approach with very minimal crestal bone. As an implantologist, I'm not a periodontist, I'm not an oral surgeon, but for years, I tried to stay more or less away from more complicated sinus lifts because of all the complications that I would encounter through the lateral approach. But now I'm very confident and readily do these as patients come in. And I don't see much problems there. So this implant design is actually kind of cool because of its safety features also put in, but this same protocol could also be done with other implant procedures, but perhaps much more risk in terms of dislodgement or initial stability, but still the concept is very solid. So aspects of convenience procedure, the failure to secure initial stability is a big problem for us in implantology. Initial stability with these longer threads are quite satisfying. And also the inter-thread bone in longer threads is much more than it is increasing the surface area between the implant and bone connection beyond the standard numbers that we see with other implant products and companies. Here you can take a look at the bone healing and the residual bone on the right versus either, this is called fit drilling. We tap it before we place it. So you could literally hand drive these implants in. That's the second pin procedure where we use the tapper versus the conventional placement of an implant in an undercut socket where you actually are causing damage to the adjacent bone as you force the implant into place, which also often leads to a necrotic layer and other problems down the road. Amount of interdental bone within the sinus, you have to understand that secondary bone healing creates weaker bone, creates weaker woven bone. So if you have more volume of it, you're going to have more stability. And that surface area is extremely important in the interdental bone, the amount that you have, the volume that you have for your long run. There are certain considerations that you have to encounter. We make custom vacuum trays for some patients. For others, we don't. I haven't personally encountered much of a problem with this, but in some scenarios, for certain diameters, you may have to expand the socket a little bit for it to seat, or if you have a cuff that's 1 millimeter, you actually have to create a millimeter to increase or reestablish your biological width. There are certain limitations that you have to look out for as you prepare. And if you're not skilled to do them under 3 millimeters, I would first start with the easier ones before I start getting into 3.2 millimeter, 1 millimeter ridges and trying to do the minimal guided scenario. So your implant placement will eventually match if done properly, and your orientation during your drilling, which you could change the angulation for prosthetic treatment. And if a sinus fluid doesn't fracture, sometimes you have to drill a little bit more or apply a little bit more pressure when you're tapping. So you check and see if you have resistance and to tapping, and if that's the case, you simply back out, drill a little bit more, maybe 0.5 millimeters, and you try it again. But the idea is to weaken the core of the sinus floor in a circular fashion where it has no other choice but to break in those areas as you tap it up. And again, very minimal bone that you would need to place into that scenario. So here's my case that I've done just recently that I wanted to show you guys, the only clinical case for the purpose of discussion, and happy to take some questions from Dr. Moghaddas on this procedure because he's an expert in implantology and oral surgery procedures pertaining to implants. But this was a case that presented to me with a disaster of a scenario that was failing. 2 implants that were placed very close to each other. The third one, probably previously augmented area and not placed properly in the center of the augmented area. And then 2 on the other side that would constantly have bone loss, bleeding, all sorts of problems. And as we see, there was something done here. But the idea was to remove all of those implants, which we did, and replace them all and in the right proper orientation and direction. Actually add a final one in the posterior region where we only had 1 millimeter of crestal bone. Here's a general overview of what happened after we completed the procedure, where you can see the lift from this angle and this angle, particularly this back one, where we did the CMC process and added bone, and we were able to sever a circular, precise area of the sinus to lift and add bone accordingly, and the patient is doing really well. But subsequently, after removing all of the implants, we placed 6 in the conventional BEV route, and 1 with the core that you can see here that was essentially raised with this procedure without any invasive protocol whatsoever. You can see from this angle again the new implants that are placed. This particular interest to our discussion, but the implants were distributed much better. Better angulation, as well as a better prosthetic setup for a better prosthetic outcome than what the patient presented with. So here you're looking at the sinus. It's still clean. We are very far up in the sinus. You still see some of the apices of the implants here, You go down a little bit and you'll see this core that has essentially been lifted in front of the BEP procedure. We call that, let's call that the CMC area. And we go further up, you see more bone sitting there. This is solid crestal type bone that's lifted with the sinus without any kind of rupturing. And then this is where our new implant starts. And this is basically what you're looking at after the bone has been inserted in that area to tune of about 0.3 cc and prior to placement of the implant. Now we have a patient that has multiple implants that are better positioned with much less invasiveness, and the patient is almost ready to be completed and restorative in the weeks to come. So that's another case, another recent case, and I'm starting to lecture more and more for this company and also for the Academy of Minimally Invasive Implantology. I like the systems, my patients love it. My costs and membranes and bone grafting materials are almost obsolete, and we carry very little bone now in the office, mostly of AUGMA type for wisdom teeth extractions and things of that sort. Most of our procedures are done very minimally invasively unless they're an immediate extraction and placement, or as mentioned, other oral surgery procedures. So I am very happy to have been able to expand my practice into sinus lifting as well. And some cases I still send out to the periodontist and the oral surgeon, but I'm become more confident in the last year and a half than I have been in the past 16 years with the sinus lift procedures. So I highly recommend our colleagues that are watching, that are interested, to look more into minimally invasive procedures. It's our belief that the future of medicine and healthcare relies on minimally invasive procedures, and we believe that also regenerative procedures will take a great strides in the years to come, as supplemented by artificial intelligence when it comes to treatment versus procedures and protocols we have been doing that carry much human error and require much manual dexterity. With that said, I'd like to take it off the screen and maybe discuss some questions that the good doctor might have.
Thank you so much, Kianoor. I truly actually, as I said at the beginning, you brought something also new for the audience. You know, in the field of sinus augmentation, if we want to compare it to different techniques, bone augmentations, we've seen so many changes in devices coming out, as you said, you know, like different type of drills, different type of, you know, hydraulic systems, like the piezo units with different tips over the years, and so many things like the balloons, like different kind of stuff in the close approaches, in the open approaches. So this was also something different. And as you said, we always look for a type of technique to minimize the complications. We know that complications can occur even in the hand of experts all the time. The percentage is going to be like 2 to 5%, but it can happen. But generally speaking, we always look for a technique to make it as easy as possible and as fast as possible to do for our patient. And if complication happens, also the management of that complication be simpler. So first of all, as I wanted to open up the discussion, and this is one of the things that I always talk about it, you categorize it two type of things in scenarios in your sinus patients. One was the cases with 4 to 6 millimeters of available bone. And the second scenario was 4 and less than that of the bone remaining for during the sinus approaches. So in the first scenario, if you have 4 to 6 millimeters of the bone, let's do this way. If you have 6 millimeters of the bone, do you think, is it necessary to do any type of sinus grafting?
For a 4 to 6 bone, no, because we can lift it up to 5 millimeters.
For 6 millimeters, not 4 to
For 6 millimeters. Okay, in that range, if it's 6 millimeters, we can lift it up to 5 millimeters. So if you wanted to place an 11, if you're one of those guys that believes length is more powerful than width, then yeah, by all means, you can go another 5 millimeters up and put an 11 millimeter implant in
No, actually,
there.
you know, you said the good thing, because I'm exactly opposite. And you know, I'm saying that if you have 6, you can place like 7 millimeter lengths or 8 millimeter lengths and done, because you know we have about 1 millimeter thickness of the sinus floor. So just drill through that and place your implant. So that's it. So that was my question for 6 millimeters. So you are in a category of doing it, putting an 11 millimeter implant in 6 millimeter of the remaining bone, or you
I'm
also
not. I'm
no?
not, but some people are. They believe more in length. I personally believe width gives you more surface area. I would agree with you that if I have a 6 millimeter implant and a 6 millimeter ridge, yes, why? Why would you? If you have enough width in the ridge and you can get enough surface area on that implant, it's completely pointless to raise it more.
Yeah.
But if you don't have that width, you need length, you need surface area, you need strength.
And now talking about length and width, because you said that you prefer the width or diameter of the implant comparing to the length. What is your limit? I want to, because I know it's nothing, it has nothing to do with the topic, but because I think it's a good question for the audience. Imagine if you have 6 or 7 millimeters of width of the bone available. What is your diameter of choice for your implant?
So I look at me needing at least 1.5 millimeters of bone around my implant, about 3 millimeters in approximately. You get too close, you get problems. So say if I had 6 millimeters and 6 millimeters height and 6 millimeter width, you can probably get a 4.5 by 6 in there, and be
What
pretty
about
comfortable.
5? What about
Mm.
2.8 or 4? Why 4.5?
I mean, you're talking about having a narrow diameter implant and a high, no, in a width.
You know, I mean, the question is this: 4.0 isn't, I believe, that isn't considered narrow. So anything less than 3.5 is considered narrow. So
Yes.
my question was this, because me personally prefer to have more bone around my implants instead of having more diameter of implants and having less amount of bone remaining. And you mentioned a great point that you need to have at least 1.5 to 2 millimeters of bone, buccally or palatally, or mesially or distally. So with that said, if you have like 6 millimeter or 7 millimeters buccolingually, and if you want to have 1.5 in the buccal, 1.5 in the palatal, so you will end up in 4 or 3.5 millimeter of diameter of implant.
Correct, but there's other considerations too, Dr. Mughaddas. If you're sitting back there and you're pounding at 200 plus pounds, thousands times a day on a molar, on a 4 millimeter implant, and you have eccentric movements and you have a bone level implant, those walls at the neck are very compromised and subject to forces. A lot of times you see implant break due to the lateral forces, especially if they're not bone driven and they're prosthetically driven. It's because the forces are not going down the center of the long axis of the tooth. They're being absorbed by the neck as well. So you have to also look at where you are and what sort of patient you got to consider. If you have any kind of wear facets on the teeth, that's the last thing I would recommend, is to have a smaller tooth, regardless of the amount of bone that you have.
Mm-hmm.
And some of these people have wide bones because their muscles and everything else and their mastication is so profoundly strong that that should be an automatic hey, be very careful with what kind of implant you put in here. You might want to have a lot of metal width so those things do not happen, or those kind of risks are minimized. So I look at many other things than just simply the volume of bone I have. But to your point, if I were the person to choose between width and height, I would certainly go with the width, because again, that's more minimally invasive.
Yeah. And let's back to the first scenario, as you mentioned, 4 to 6 millimeters of available heights comparing to less than 4. So in the cases that you have 4 to 6, less than 6 millimeters, You, in your technique, the scenario, as I understood, was you drilled about 1 millimeter to the floor of the sinus, and then with that a specific magic cord drill, I believe, if I remember it,
Yes.
you try to fracture the sinus floor and lift it up with the implant itself.
Yes. So what you do is you create a circular, essentially a circular scenario where you're weakening the bone. You never fracture it with your drill. That's subsequently done because you have weakened a circular area. So
But
now any force that you apply, then you take a tapper and you gently tap it. No matter what force you apply, it's going to cause those weaker areas to break first, and the core will not break. Conventionally, when I was doing my fellowship and they were teaching us sinus lifts, they're telling us to take the stick and cause a green stick fracture. But the concept I don't understand, because you're applying force directly in the center of an area which you could go right through. You're gonna want to have it controlled and measured, so you end up about 1, and the other scenario 2 millimeter under, so you can go ahead and actually apply your tapping force and break it. But you ultimately got it right. We never want any instrument to touch the sinus membrane in any shape or form. We want to weaken it and in a controlled fashion tap it until we raise it to the point, because we know we can raise it X amount of millimeters depending on the scenario due to the knowledge that we have about the Sharpie's fibers and how elastic it is. And then the blood gushes in, but that thing doesn't fall in right away. It's still recommend that you go in with a drill and open it so it can receive the implant accordingly without much resistance.
now,
And then your implant will eventually go up to the core.
one of the issues that I think we can have is that when you fracture that piece of core at the floor of the sinus, and then you want to place your implant, and that core on top will go with the Schneiderian membrane to the top. What about the irregularities that may occur around this core? And when we lift it up, these irregularities may cause the sinus perforation. Do you find it as a possible problem in this procedure, because you cannot identify if anything has happened or not?
Great question. There are irregularities always in the sinus, as you know, and the closest one to your instrument will break first. So if you have a dip, wherever the edge of that instrument is, that will break first. So sometimes as you're doing this procedure, the core will lift this way, like one side of it will lift up and the other side of it subsequently lifts up. I haven't had the issue where I've actually perforated as a consequence, or the bone causing the rupturing. But what I do know is that sometimes oral surgeons go in 1 or 2 millimeters or more into the sinus without even worrying, which is, that doesn't work for me because I always have infection and everything else. But they do it, and they don't consider it as malpractice. Having a very minute rip in your Schneiderian membrane in the most vascularized tissue in your body, one of the most vascular tissue, it will immediately heal. Where we get into trouble is when we put instruments and other things into the sinus, and then the sinus says, oh, this is a foreign body. But a minor rip automatically corrects itself very, very quickly also.
Yeah.
If that happened. That's my theory, that why we don't have this issue.
Yeah. And also just bring that question in your last case, which was in the second scenario, when you have less than 4 millimeters of residual bone height available. And the case that you showed, the very last one, I think the remaining bones was about 1 or 2 millimeters remaining.
Correct.
Yeah. So in that case, you also had the same approach, and we can say it was like a crystal, and you lift all that remaining height up. So, and you place your implant at the same time.
Yes.
So now,
okay.
Now the hardest question that I can ask you is this, that gaining the primary stability is one of the issues that we should take into consideration when we want to place our implant simultaneously in the sinus. So with your specific implant design and engaging to the remaining walls available, you were able to achieve that primary stability without a doubt. But now the issue is that having the primary stability is one thing, but maintaining that stability over time in the next 4 to 6 months before loading is something else, where that remodeling may occur and there is a very little amount of bone available around your implant, and mostly it's cortical, and so the remodeling rate going to be even higher. So what is your concern in your decision making when you want to place your implant at the same time in that little amount of bone available? And do you have, I mean, do you see any concern? Because I see the concern.
Yes,
But
I see your concerns, certainly. And on the 1 mm scenario that I showed you, I actually use a trephine burr to get close to the sinus versus the magic burr. But to specifically answer that question, yeah, I do see that risk of initial stability in the remodeling, and I understand all that. But in scenarios that are 1 mm or 2 mm, 3 mm, you have to be kind of sort of skilled in doing that. You're not saying get in there and do that right away. Scenarios of 4 to 6, yes, you get your initial stability. You can even at times load it. And definitely on the 1 to 4 scenarios, I never even consider loading. We do make a suck down for the patient. The magic cord does stick above the gum. The margin usually lines up at the gum to minimize the whole invasive aesthetic issue. So ultimately, there are multiple other things that we try to do to stabilize the implant and prevent it from dislodgement. But obviously, no chance to load. You have to take the process. And I could foresee some people having issue. The thing with this particular system is it has very, very deep threads that are sort of also sharp and squares. So even in the 1 mm scenario, as it rotates, it doesn't go straight. It's in an angled scenario, or the pattern. It really digs into the crestal bone so profoundly that initial stability is like you have placed it in rock solid bone, which is very. I'd have to actually physically show you with a forceps after it's placed. It's not a scenario where remodeling alone will be able to dislodge all those threads or the thread engagement.
mm-hmm. So I mean, because the thing that I was thinking when you were talking about it was that,
Great questions.
is it an implant a specific technique, can we say, or with every type of implants is it possible to go with the same approach?
The founder of the organization of the Academy of Minimally Invasive Implantology is a gentleman out of Korea with 37 patents, who also founded several implant lines. His recommendation and his thought process was based on his own scenario. But I have done modified procedures using a trephine burr, where I wanted a bigger cord than what it would provide me. So I would drill with a trephine burr, a millimeter short of the implant, and I would use my tapper. You know how you have a tapping instrument? I would use my tapper to tap in and use the force of that rotation to break up the lower part. So I personally think that there are applications for this with every implant system. I would highly agree with you that under 4 mm, probably no other system, unless they have deep threads, would work to get that initial stability that you would need. That's a very accurate scenario by you. But I would think that the general concepts of breaking the cord that's attached to the membrane and gently lifting it could have a profound effect on how we do it minimally invasively, and it's a logical scenario.
And you talked about the graft materials that you have minimum amount of graft material in your office regarding these type of techniques. So I want to know, in case that you want to place a graft material, specifically in the last cases that you showed where the amount of bone was very minimum, what type of graft material you prefer to choose? Is it going to be like potty bone, or the particular bone, or any specific device or instrument you have for placing that graft material and pushing it inside with having that amount of core available there?
Yeah, the core and the membrane still being intact, or even if you had a small rupture, you'll have very minimal seepage to it. But you want to use powdered bone, probably use it with an aesthetic. I mix it mineralized, demineralized mix type scenario and carry it to the site, or even using an amalgam plugger if you need to put it in there. For bigger oral surgery cases where I have bigger openings, I've been putting Ogma biomaterials in from Dr. Amos, and that brought that to the market. It works out pretty good for me. But for oral surgery procedures like this, implantology procedures, I use much thinner sutures and powdered bone, have a little better control of what I want the outcome to be.
Yeah, you know, the reason that I asked the question was that uh, specifically, I'm going to say it again, the severe cases when we have only 1 to 3 millimeters of available bone, as you said, the sinus membrane have the ability to repair itself, but in case of any rupture, even a small, because we cannot see and it's completely blind, the reason I asked about the material was that in case of any rupture, if we cannot see, if we cannot be sure that it's there, and if we place our material inside and it go inside the sinus, then it can encounter a problem. So that was why I asked about your material of choice, because I thought that maybe you prefer to go with the smaller size materials or putty type of bone to make it minimizing the spreading of it even at the time of exposure.
I have experience with like Ogma and stuff like that, but when you place the implant and the stuff disintegrates and gets replaced by your own bone, it's not the type of scenario I would want in a complex scenario. I want to make sure that bone stays. I want to be able to carry it easily and make sure that, you know, once I mix it with an aesthetic or what have you, that I can control it very well and place it very well. If the scenario is there and you don't verify with a CT afterwards and it has seeped into your sinus in some shape or form, you need to abort and take the complications measure. I would not recommend proceeding any further. But as you know, the bone will eventually clear to your sinuses, and you start back over again. And you got to go and do all of the different regimens with Afrin and Sudafed and Augmentin, all the stuff that comes in, saltwater rinses, but you have a lot more risk getting that scenario by taking a cred and try to separate the membrane from a lateral approach, or going in blindly from the vertical and trying to create a green stick fracture. You have a lot more chances. Even the green stick fracture concept, there's so many sharp pieces that you create that are rupturing the sinus, guaranteed. So we don't encounter that problem because there is still some bone, cortical bone, that prevents that material just gushing into the sinus. In this scenario, we have a core that has not been broken. So it's much harder because as you insert the material, you keep inserting it under the bone, under that bone. But in a case you have a complication and there's a rupture that you can see, certainly possible that you do get some bone material, regardless of what bone material you use. It's going to go up there.
Yeah, good point. And as I said, your topic is going to be interesting. So I had so many questions in my mind for the audience also. But my last question, I just want to know your thought on that. What is your thinking comparing these type of approaches, comparing to osseodensification approaches like drills, compacting the bone and putting into the apical? If you want to have a comparison, I know all these techniques works and it depends on the skills, it depends on the preference of this practitioner, but as a person that you've worked with this type of approach and you were very successful about it in different kind of severities, I want to know what's your comparison between these two type of techniques.
You know, I work with Dr. Sohn, I work with Dr. Mazur. You know, Dr. Sohn does the water technique, Dr. Mazur has the osteodysplasia. I respect their procedures and protocols very much, and I've attended some of their lectures on those, and they work. No, undoubtedly, there are scenarios that work, and the question is what works best for you in your hands and in your beliefs. I also work with Dr. Nisnik, and Dr. Nisnik doesn't believe osteodensification works. His belief is that, you know, you could place an implant in an undersized socket, for example. Whereas there are disagreements between leaders of industry. None of them are wrong, the technique of osteodensification has proven over and over to work, and so have many others. But for me, I think that if I were to choose another technique, the osteodensification would be probably the closest one that I would use, because I personally am not convinced that when you take allograft from one human to another human, that you can completely eliminate all the prions and all of the different things in the genome and what comes with the bone graft material. In my personal belief now, after all these years of practice, I think that the bone grafting material might hinder healing, hinder natural healing. So when you're doing something that's autologous and something that is minimally invasive, like osteodensification, I'm all for it, especially autologous. And in my bone grafting materials that I use now, I try as much possible to use synthetic type materials like OGMA, where I know for a fact that what I'm doing for that patient is in the best interest of the patient, or facts that I can't control of what they do at tissue banks and what they put out there for bone grafting material and membranes, and the tens of thousands of dollars I used to spend on this material that may have inhibited my patient's progress. But those procedures are good. I think the future of dentistry and medicine as a whole will be based on minimally invasive procedures, not because us as doctors believe other procedures are good, because the patients want it. And when the patients want it, you got to get in line with it. They want less pain, they want less appointments, and they want faster healing. And if you have procedures that provide for those things, you should explore them and improve them.
Absolutely agree with you. Well, Kianoor, thank you so much for your time. I truly enjoyed talking with you and have this hot conversation on the topic. And thank you for the points. Thank you for, you know, providing so many opportunities for so many dentists around the world and have a very open door for everybody. And I'm pretty sure everybody have that appreciation. And for those of you watching, I truly recommend you all to go to his Facebook page and Global Implantology Institute. You can find so many great stuffs for learning there, and also so many of our great colleagues being involved in Kianoor's program. And me personally had a chance and honor to be involved in it. So thank you so much, my friend, for your time. Really looking forward to see you again soon, and hopefully in person in the future. And hats off. Thank you.
Yes, thank you for having me. It was an honor to be on here. And now I understand why it's called the hot seat. You're the man with all the good questions, the quick questions. And I really enjoyed it. Thank you once again. I look forward to working with you in the future.
Sure. Thank you so much. Have a great day.
To take care.